So, welcome everyone to this session on basics of asthma. I'm Vaishali Naik from the Medical Affairs Department, Sipla. So, I'll be taking you through the basic understanding of asthma. What is the definition? What is the prevalence of asthma in India and across the globe? How do you diagnose asthma? And what are the basic treatment modalities for managing asthma patients? So, this is what is going to be covered in this module. To start off with, let's have a look at the prevalence of asthma. It has a huge disease burden across the globe with around 300 million patients affected with asthma and equally high number in India as well. The prevalence of asthma in India in adults above 15 years of age is around 2% of the entire population. And it is estimated that the prevalence is increasing 50% every 10 years, maybe because of the poor quality of air, the poor quality of diet that we have. So all this is leading on to increased prevalence of asthma. There is this interesting Asia Pacific AIM survey which was conducted. This survey was conducted across various countries across Asia and the Pacific region and also involved India. Some interesting pointers from this survey, and they evaluated asthma control in asthma patients, and it was found that 100% of asthma patients in India are either uncontrolled or partly controlled. Why? Because 42% of asthma patients reported having daytime symptoms every day. 32% asthma patients in India reported having nighttime symptoms every night. So this shows the poor quality of asthma control. Patients are suffering from symptoms and their asthma is not at all controlled. Especially look at the exacerbations. 67% of patients reported exacerbations in the previous year. And we know that the guidelines for managing asthma clearly point out that you should look at reducing the risk of exacerbations. 78% of asthma patients in India reported missing school or work in the last 1 year, which clearly indicates that there is activity limitation in asthma patients. So overall, from this survey, what we understood is it's a grim situation for asthma patients in India. So although you have good quality medications, combination drugs are available, a variety of inhaler devices are available to provide these drugs directly into the lungs. Despite all this, you still have so many patients who are not controlled. And there might be various reasons behind it. A major reason being lack of awareness at the level of the patients. And also, many times, asthma gets undiagnosed or it is misdiagnosed at the doctor level. So, overall, there is a requirement to spread the knowledge on asthma amongst the masses and also educate doctors on the newer modalities available for diagnosing and managing asthma patients. Suppose this Asia Pacific AIM survey, let's have a look at another interesting study which was done. This is the Poseidon study. So generally what happens is it is the heart which is considered very important and not the lungs. Even if you speak to the general population, you will get to know that they have a fair bit of understanding on hypertension, diabetes, and cardiovascular disorders. However, when it comes to the respiratory problems like asthma and COPD, we'll see that they have hardly any information. They're not even aware about terminologies like COPD. So this Poseidon study actually tried to understand how big is the respiratory problem in India. So this was a huge study. You can see that it was conducted in around 880 cities and towns in India, and around 2 lakh doctors were involved in this survey. So we had general practitioners and pediatricians who participated in this survey, and they had to fill in a form, and based on the form in a day, which are the different types of patients that they come across was evaluated. As you can clearly see from the graph, nearly 50% of the patients had some or the other kind of respiratory problem. It might be a cold, cough, it can be asthma, COPD, pneumonia, tuberculosis. But 50% of all the patients reporting to a general practitioner had a respiratory problem. And that clearly shows us the importance of the lungs. Majority of patients have these disorders and hence doctors need to pay more attention to the respiratory problems. Further bifurcating into the respiratory section, the study also tried to evaluate the percentage of OADs, that is obstructive airway diseases like asthma and COPD, and they found that 14.51% of the patients had asthma and COPD, and this was the second most common diagnosis, just a little behind hypertension, that is 14.52%. So clearly showing that, when it comes to OADs, it is not less than hypertension. But when it comes to awareness, patients are hardly aware about the condition OAD. So the Poseidon study showed that the respiratory symptoms were the leading cause of visit to a healthcare provider across India. 0.6% of adults and 65% of all pediatric patients had issues related to respiratory condition. So there are some interesting findings from the Poseidon study, which also you can share with your doctors. It's an old study, but nevertheless, it's very interesting and it gives you data across India. Next, now let us get into more details about asthma. So let's have a look at the definition for asthma given by the GINA guidelines, which is a global initiative for asthma. According to this definition, asthma is a heterogeneous disease. It is usually characterized by chronic airway inflammation. So we all know that there is inflammation in the airways that is persistent. However, what this definition is also talking about is the heterogeneous disease. That means asthma is different in different patients. It is not the same in all patients, and you need to evaluate each and every patient on an individual basis. Further, the definition also says asthma is defined by history of respiratory symptoms such as wheezing, shortness of breath, chest tightness, and cough. So wheeze is like a whistling sound which comes out of your airways when you're trying to exhale out. And because you're trying to force out the air against the narrowed airways, you get a whistle type of a sound. Shortness of breath is the breathlessness, which is the difficulty a patient faces while trying to breathe. And a lot of cough, and all these symptoms, they vary over time and in intensity, together with variable expiratory airflow limitation. So how do you measure asthma? You measure in terms of your peak expiratory flow rate. And that varies depending on your symptoms, depending on your lung function. So all in all, this guidelines is trying to tell us that there is chronic inflammation in the airways. Asthma is different in different individuals. That is why it is heterogeneous disease. You have all these four classic symptoms, and these symptoms may be present in some or the other individuals. One asthmatic may not have all these four symptoms together, and these vary over time in intensity along with a variable expiratory airflow limitation. So this is defining asthma. Let's move ahead and try to simplify the definition. This is a very simple understanding of asthma, ABC, wherein A stands for asthma is a chronic inflammatory disease characterized by airway hyperresponsiveness. So your airways are twitchy or your airways are overreactive to a variety of stimuli or the triggers, resulting in bronchospasm. So this is how you can understand hyperresponsiveness. You must have seen these touch me not plants. What happens when you touch the leaves of these plants? They are oversensitive. They're not like the other leaves. So as soon as you touch them, they shut off. Same thing is happening in the airways of an asthmatic patient. Whenever any foreign particle enters inside, because the airways are hyper responsive, overreactive, they give you an exaggerated or an increased response to the triggers. So that leads to bronchospasm. The way the leaves are shutting down, same, your airways shut down, or you can say collapse, or they constrict, which reverses spontaneously, or it might require treatment. So you have airway hyperresponsiveness followed by bronchospasm, and you have chronic inflammation. So this is the ABC of asthma. Now, having a look at the touch me not plan, we have understood that asthmatics are not like the normal population. They are little special. Why? Because these individuals are allergic. So they overreact to a foreign particle or a trigger. And this overreaction is called as the allergic response. So what is happening inside the airways is the trigger is entering inside and the airways go into a bronchospasm and there is inflammation which is produced along with the bronchospasm. So let us try to understand step by step what is happening inside the airways. So to go in a scientific way, first what happens is it is called as the sensitization phase. So this is the first exposure of an allergic individual to a foreign particle. For example, say a pollen grain. So when he inhales a pollen grain for the first time, what happens? The pollen grain, it actually stimulates the person's allergic response and he produces excess IgEs. And this excess IgEs help to destroy the pollen. At the same time, the excess amount of IgEs, they bind with the mast cells. The mast cells are present in your blood circulation. So mast cells get sensitized and various inflammatory mediators are produced within the mast cell. However, the mast cell is intact during the sensitization phase and hence nothing is released. And if you look at the patient, he will have no symptoms. So this is the first exposure. Patient even does not come to know he has inhaled the allergen because there are no symptoms as such. Now, if the patient inhales the same pollen for the second time, that is the second exposure, this is called as the early allergic response. So immediately within 5 to 30 minutes after exposure to the allergen, he will start feeling bronchospasm, breathlessness, difficulty in breathing. Why this happens? Because now the allergen which enters inside, it binds to the IgE already present on the mast cell. And hence the mast cell degranulates or it ruptures. And whatever inflammatory cells were produced inside, they are now released. So imagine a balloon which is filled with sprinkles. You must have seen during birthdays, you burst open the balloon and all the sprinkles are spread. Similarly, now the mast cell degranulates and all the inflammatory mediators are released. The ones which are very quick to act, histamine, it acts within 5 to 30 minutes and you immediately get a bronchospasm. There are other inflammatory mediators like prostaglandin, leukotrienes, which are also released. They start their action little later. This is called as the late allergic response or the during the second exposure. This late allergic response starts happening after 3 to 11 hours after the second exposure. So the slow acting inflammatory substances, they further attract inflammatory mediators into the lung tissue and inflammatory cells like eosinophils, basophils. These are all increased in the lung tissue. They further produce inflammatory mediators, chemicals, and they bring about inflammation in the airways. So all in all, during the allergic response, you will see that during the second exposure, the thing that quickly happens within 5 to 30 minutes is your bronchospasm, basically because of histamine. And during the second exposure, after 3 to 11 hours, slowly what starts happening inside the lungs is a lot of inflammation starts to happen inside the lungs because of the eosinophils prominently and basophils and neutrophils and various inflammatory mediators that are released. So this is giving you a basic idea of the allergic response inside the airways of an asthmatic person. This is a simple one to understand. We all know the different triggers for asthma patients. So what are triggers? They are factors that when inhaled can increase your asthma symptoms. One thing that you must remember is they can vary from person to person. Okay. So these are various triggers, dust particles, this dust mite, which is present in your curtains, sofas, blankets, if not cleaned properly, animal dander, pollen from plants, damp walls, molds and fungus from these damp walls, firecrackers, smoke from industry, cigarette smoke. For some patients, it might be the strong smells from perfumes, cold air, in some patients. Generally, you must have seen during the winter season, you have more exacerbations of asthma. And also many asthma patients have exercise induced asthma. That is when they perform a brisk activity like, jogging or running. So immediately they start feeling breathlessness. So these are various triggers, and each individual would have his own triggers that will increase his symptoms. And it's very important for any doctor to find out or recognize the asthma triggers for that patient and avoid them. This is the first step towards controlling your asthma. Okay, but as you have seen, there are a number of triggers. Smoke is everywhere, dust is also everywhere. So how much can you avoid it? So along with avoiding the triggers, your pharmacological agents also become important, which will help prevent getting an exacerbation. This is a very simple diagram to explain to you what is happening inside the airways of an asthma patient. So on the left hand side, you can see this is the normal bronchiole. I hope you all understand what is a bronchiole. These are hollow tube-like structures, and these are the muscular bands which constrict and you get a bronchospasm. And this is the lining of your airway, which gets inflamed, and your hollow lumen decreases, or the open space decreases, and the patient is not able to breathe. This is what is exactly happening in an asthmatic bronchiole. So maybe this patient has inhaled a trigger or a foreign particle. The airways are getting into, the muscles are getting into spasm, plus a lot of inflammation. You can see this red part, and the yellowish part is the excess mucus which is being produced. So all this is obstructing the flow of air, and that is why the patient feels breathless and he is unable to breathe. It can also lead to coughing because of the excess mucus that is produced. So immediately, if you have to give relief to this patient, you need to give him something that will relieve the bronchospasm. Okay, so these are called as reliever category of drugs, which quickly act and produce bronchodilation. However, these are to be used only as SOS as and when required, because your everyday therapy has to take care of this persistent inflammation which is there in your airways. And hence a daily therapy with an inhaled corticosteroid, which is a potent anti-inflammatory drug, is very important. And the same thing can be explained to patients using the 3-tube model which we have, which clearly tells the patient, the difference between a normal airway, asthmatic airway which is inflamed, and the asthmatic airway during a attack. So these are various tools which we have developed, which will help in patient education also. Now, having understood what is asthma, what is the guideline definition, what are the triggers, let us try to understand how does the doctor go about diagnosing asthma. So diagnosing asthma, very important over here is history taking. You have to sit down with the patient, try to understand his symptoms, the frequency of symptoms, and what is triggering of his symptoms. Second is physical examination. Try to evaluate the patient. Try to hear the wheezing sounds, the rhonchi with the help of a stethoscope. Measurement of lung function to finally conclude, okay, whether the patient has asthma or not. So this is going step by step for the diagnosis of asthma. And then you can confirm whether he has asthma by the bronchodilator reversibility test using a bronchodilator like salbutamol or levosalbutamol. So these are the various asthma symptoms. In the history, while you're consulting the patient, you need to understand what type of symptoms is he suffering from. So if you come across patients who, complain about breathlessness during night time or after some exertion, this is a classical symptom of asthma. Wheezing, that is a whistling sound, that also is a symptom for some of the patients. And wheezing and cough, especially these are very prominently seen in children. Especially during night time, children get up with a cough and it's difficult for them to sleep. So these are the typical symptoms in pediatric asthmatics. And because of all these things, the patient feels chest tightness, a feeling of congestion in the chest. So these are various symptoms. Again, all patients may not complain about all the four cardinal symptoms. Somebody might have breathlessness and wheezing, somebody might have breathlessness and coughing. So you need to evaluate each and every patient accordingly. These are various questions which you need to ask during history taking. This is just giving you a idea about some 3-4 questions which we have jotted down. So check whether the patient has a troublesome cough, particularly during the night time or early in the morning when he gets up. Does the patient cough after physical activity, example playing or brisk walk? Does the patient have breathing problems during a particular season, for example winter season or rains, monsoons, if there is increase in his symptoms? So asthma is typically, most of the patients you will say it is seasonal. Do the patient's colds go to the chest or take more than 10 days to resolve? So that indicates it's not a viral infection, it might be asthma. Does the patient use any medication, example bronchodilator, when symptoms occur? For example, he might be taking some oral medication which has a bronchodilator, but he gets relief after taking the medication, although it is not a sustained relief. But that is an indication to the doctor that there is some spasm in the airways which is responding to that bronchodilator medication. So these are various questions which you can ask to diagnose asthma. Also, if the patient is answering yes to any of the above questions, you need to suspect that this can be asthma. Also, a doctor should ask about, does anyone else in your family suffer from asthma, allergies, or frequent colds? Why? Because asthma is a genetic condition. So if anybody in the family, like father, mother, grandparents, uncle, aunt, anybody has asthma or any other allergy for that matter, skin allergy, allergic rhinitis, so there are more chances that this person whom you are evaluating would have asthma. Okay, so this is an important question to ask. Further, once you start suspecting that this patient has asthma, you need to confirm. So for confirmation, you can do spirometry, which is the gold recommended standard for diagnosing asthma. And in cases where you do not have a spirometry, doctors can also use the peak flow meter. So peak flow meter is a very simple to use tool. You do not require any electricity. It's not a sophisticated device. You get the reading immediately. And the reading is also easy to understand. It is easy to perform the breathometer test. You don't require a qualified technician to train the patient how to use the breathometer. So it is called as a thermometer for asthma because it gives you a reading and that tells you where do you stand, what is the severity of your asthma. And this is also available from SIP. It helps to measure your lung function. Now, bronchodilator reversibility test is a very important test that helps you confirm whether the patient has asthma. So although spirometry is the preferred diagnostic tool, bronchodilator reversibility can be performed using a breathometer. How do you do this test? You measure the PFR readings. So best of the 3 blows are taken. Note down that reading. Administer a bronchodilator, salbutamol or levosalbutamol as 2 puffs with the MDI or 1 inhalation of the rotacap with the rotahaler or the revolizer. Wait for 15 to 20 minutes for the drug to have its action. And then again, measure the PFR reading of the patient and take 3 blows, and best of the 3 blows is to be noted. Look at the change between the first and the last reading. A 20% or more improvement after inhalation of a bronchodilator suggests a diagnosis of asthma. Okay, so along with a good history, physical examination, the bronchodilator reversibility test helps you confirm asthma in a patient. This is a spirometry test, spirometer, and as we have discussed, it is a sophisticated device. It gives you a better evaluation of your lungs and also your smaller airways, which is not possible with the peak flow meter. It helps measure the FEV1, and a trained assistant is required to help the patient use a spirometer. increase in FEV1 of more than 12% or change in PF of at least 20% using a peak flow meter, if spirometry is not available, helps to confirm the diagnosis of asthma. Okay, so after having diagnosed asthma in the patient, how do you proceed with the guidelines for asthma? So I'll take you quickly through some basic understanding. Of course, it requires a quite detailed session. But right now, what we will be looking here is, preliminary understanding for managing asthma. So according to the guidelines, what are the goals of asthma management? So one is symptom control. So the patient's symptoms should be under control, like wheezing, coughing, breathlessness. And second important goal is reducing the risk of exacerbation. Because understand that exacerbation can lead to hospitalization, requirement of oral steroids. It can also lead to mortality, and it is a huge burden in terms of economy to the patient. And also, it leads to deterioration in his condition. With each and every exacerbation, your lung function keeps on dropping. And hence, these two goals are very important when you're looking at managing asthma patients. Coming to the treatment part of asthma, now since you're dealing with lungs, a major question arises, how would you like to administer the drug? Should you use oral tablets, pills, or solutions, or should you go for an inhaler? So, what has been reported in various papers and guidelines is oral drugs, you require a large dosage, and that increases the side effects. The drug enters into your GI tract, and from there it will be absorbed. It reaches into your systemic circulation, increasing the side effects. And only a minor fraction from there goes into your lungs to produce the required effect. Okay, so most of the drug is wasted in the systemic circulation, leading on to various side effects in various tissues and organs. Onset of action is reduced because the tau has a slow onset. It has to first enter into your GI tract and then it will go into your lungs. And hence it is not useful in acute attacks. Compare this with the inhaled drug. You have PMDIs, DPIs, inhaler, nebulizer, synchro breathe, various inhaler devices which are available. So what happens with these devices, the amount of drug required is very small, microgram quantities, and the drug directly gets into your lungs. So that reduces the side effects. The drug does not go much into the systemic circulation. It directly goes to the target organ, produces the benefit or the therapeutic effect, side effects are reduced. And since it is going direct into the lungs, you also get fast onset of action, especially required during acute attacks, and you get quick relief with reliever drugs that help produce bronchodilation, and therefore it is useful in acute symptoms. So oral drugs are a no-no for management of asthma, and all the guidelines and publications especially focus on inhaled drug delivery for managing asthma and COPD patients. So we now know that asthma is bronchospasm and inflammation. For the bronchospasm, you need a reliever. You can watch the video to understand more how a reliever produces bronchodilation. We have salbutamol and levosalbutamol. They are the most widely used relievers. So this is what happens with the reliever. This is your airway, which is constricted and inflamed. On using a reliever, you get bronchodilation. The muscles relax and the lumen becomes now wide open, and it's easier for the patient to breathe. The symptoms reduce, like breathlessness, coughing, wheezing, they reduce because your airways have now opened up. But what still remains is this red thickening or the inflammation. So that inflammation requires something else. It requires a controller, which is inhaled corticosteroids or inhaled corticosteroid with a long-acting beta agonist LABA. So these drugs help to reduce the inflammation. And you can have a look at this video to understand how the controllers reduce the inflammation. So this is how or what is happening inside your lungs. After taking your controller medication, you can see that the inflammation has reduced drastically. So this also helps to reduce the hyper-responsiveness of your airways and prevents any future attacks of asthma. So coming to the drug treatment, we have basically two categories of drugs, relievers and controllers for managing asthma. Typically, relievers are bronchodilators and controllers are anti-inflammatory. They act on the inflammatory component of asthma. Example is a short-acting beta agonist like SABA, Levolin, levosalbutamol, salbutamol. And over here you have anti-inflammatory drugs like inhaled corticosteroids or the inhaled corticosteroids and the LABA combination. The main role of relievers is to quickly relieve the symptoms, and for controllers, it is to prevent asthma attacks. Here, the onset of action is faster, and for controllers, the onset of action is little slow. It is not so rapid as within 2 minutes. Okay. Duration of action is short, and here the duration of action is long. These are mostly, the relievers are mostly used as rescue medication, that is SOS, and the controllers are used as your regular medication. You have to use it continuously as has been prescribed by the doctor, irrespective of your symptoms. So whether you have symptoms or you do not have symptoms, you have to continue using the controller medication because it will keep on giving you benefits in terms of reduction in your future attacks. So these are few examples of controllers that are used in asthma as daily treatment. So inhaled corticosteroids, you have budesonide, Budecort, fluticasone, Flohale. Also have cyclizonide, which has been recently introduced, Cyclohale. ICS LABA combinations like salmeterol, fluticasone, Seroflow, formoterol, budesonide, Foracort, small particle formulation, formoterol, beclomethasone, Nivioli, and formoterol, fluticasone combination, Maxiflow. You also have the oral tablet anti-leukotrienes, Montelukast, which is Monter. But the efficacy of Montelukast is not so great compared to the inhaled corticosteroids because ICS give you a better coverage of the inflammatory mediators as compared to Montelukast. That can take care of only the anti-leukotrienes, whereas ICS can provide anti-inflammatory effect against various different chemical mediators. So the potent anti-inflammatory agent available for asthma is the ICS. And these are to be taken regularly whether the patient has symptoms or not. So key points to remember, there are many patients who are suffering with asthma. The prevalence is high globally and also in India. The Poseidon study shows high prevalence of respiratory patients and physicians and clearly indicating that it is really required for doctors to take account of respiratory problems. An early allergic reaction starts within 5 to 30 minutes after inhaling the allergen for the second time, and that leads to bronchospasm. So histamine, prostaglandin, prostacyclin, leukotrienes, these are various inflammatory mediators which are produced during the allergic response. And the inflammatory mediators start acting after some time, 3 hours to 11 hours, they start producing inflammation. ICS and LABA combinations have been recommended as, along with ICS, have been recommended as controller therapies. And 20% improvement in PFR using a peak flow meter is generally used to confirm asthma using a bronchodilator reversibility test. Controllers like ICS, anti-inflammatory drugs to be taken regularly and reliever to be taken only as SOS. So these are various important pointers which you should be aware of in the basic part of asthma. So thank you all for listening and hope you have understood this module.